Welcome to the Gerontological Society of America's Momentum Discussion, where we explore the groundbreaking topics and advancements that are generating significant excitement in the field of aging.
Welcome to this GSA Momentum Discussion, Dynamic Innovations in Alzheimer's Disease and Dementia. Momentum discussions highlight topics experiencing great momentum in the field of gerontology. GSA thanks the CARE Brain Health Supporter Circle members, Eisai, Genentech, Lilly, and Otska, for their support of this momentum discussion and the GSA Care Toolkit for Brain Health. My name is Jen Pettis, and I'm the Director of Strategic Alliances at the Gerontological Society of America, or GSA. I'm pleased to welcome and introduce our moderator and panelists for today's webinar. Our moderator is Dr. Katie Selzler, Medical Affairs and Scientific Communication Lead for the Davos Alzheimer's Collaborative Health System Preparedness Program. Dr. Selzler is joined by Amy Bain, Senior Health System Director at the Alzheimer's Association, Dr. Malaz Bustani, Richard M. Fairbanks Professor of Aging Research, Professor of Medicine, Adjunct Professor of Surgery, Founding Director and Implementation Scientist at the Center for Health Innovation and Implementation Science at the Indiana University School of Medicine. Dr. Bustani is also the Director of Care Innovation at Eskenazi Health. Patty LaFleur is the Youth and Lighthouse Outreach Lead at Lorenzo's House. And we're also joined by Laura Metters from Emory Integrated Memory Care, where she's a licensed clinical social worker and the administrative director. Thank you all for participating in today's momentum discussion. And Katie, I'll turn it over to you now.
Thanks so much for the introduction, Jen. As Jen mentioned, my name's Katie Selzler, and I support the DAC Healthcare System Preparedness Team. And our program role is to better understand how new innovations can be implemented into real-world practice, and so healthcare systems can be ready and help ensure the right patients receive the right interventions at the right time. In this field, there's been several new and exciting innovation in Alzheimer's disease and dementia in the past couple of years, including breakthroughs in diagnostics and therapeutics, along with continued discoveries around risk reduction. This past year also brought upon the new GUIDE model from CMS, and we're going to talk a little bit about that during today's session. I'm really excited to be joined by this expert panel to discuss advances in diagnostics and treatments and consider new innovations that are on the horizon that might improve care and outcomes for individuals at risk or with Alzheimer's disease and other dementias in their families. So Amy, I'm going to kick it off with you. So we know the Alzheimer's Association reports that about 2/3 of Americans have at least one major potential risk factor for dementia. Can you tell us more about these potential dementia risk factors? Are there any modifiable risk factors that folks should consider in order to reduce the risk of cognitive decline?
Thanks, Katie, for that question. And certainly thank you to the GSA for continuing this conversation and bringing us all together to have this webinar. What is exciting, I think, about the question that you just asked is that we're starting to focus more and more on this expanded continuum of brain health and the dementia journey. So we're no longer just focused on someone receiving a diagnosis and getting on the right care path, although we know that's still extremely important. But now we're starting to think about risk reduction and what does that mean as we continue to age. We know that there's both modifiable and non-modifiable risk factors. And in this case, we'll talk specifically about those modifiable risk factors, those that we know we can adjust and or adopt into our lifestyle. The one of the few that are most notable would be physical activity, and certainly making sure that we're remaining active, not starting or quitting smoking, and then overall just being heart healthy. So managing a healthy blood pressure, looking at other comorbidities like diabetes, obesity. They say what is healthy for your heart is also good for your brain. And I think we also need to keep that in mind. Additionally, some of the other modifiable risk factors that we're hearing more and more about include sleep, making sure that we're getting a good amount of sleep and we're developing good sleep patterns, reducing traumatic brain injury, looking at things like social engagement and what it means to have those social connections, and then things like sensory impairment. So hearing aids, what that can do to help reduce the risk of developing dementia or lowering those risks. The good news is that many times these are coaching conversations that we know are happening with patients at the primary care level. Now we're really just hoping that we can continue to make those linkages to these lifestyle changes so we can make positive impacts on brain health.
Katie,
You
can I,
should-
Katie,
Yeah,
can
go
I
ahead,
just
Noah.
add one thing? I know Amy's report of lifestyle came over from the Lancet, which is really good, but the Lancet missed on one very important modifiable risk factor for Alzheimer's disease and other related dementia, which is deprescribing bad medication. I think that's a good, number one, it's good for our Medicare and health insurance to stop medicine that is not going to work and it actually make you waste your money. It's good for our patient. It's reduced their out-of-pocket cost. And obviously, it's also help them keep their brain healthy. And this specific class of medicine is very prone in underserved population in particular, and those who have no genetic susceptibility for Alzheimer's disease, so the least vulnerable. And these class of medication, we call them anticholinergic medication. They are available over the counter like Benadryl and anything with sleep aid, like the word PM after that, dicyclamine, for example. And then some of them are prescribed medicine that we use for bladder management, for sleep, for pain, even for nausea and vomiting. The signal there is so strong that right now we are trying to figure out through clinical trial, is their effect reversible or not? If you have cognitive problem because you've been taking it for quite some time, if you stop them, do you recover or not? Or is there specific threshold that you don't really want to be exposed to disease medication in the first place? Because if you expose, then you have damage, then it's very hard to recover from the damage. So I just want to add that, Amy, and I know it's not part of the Lancet report. I don't know why, but that's important, at least for my patient, when they come over to the clinics, they are very much interested, not just for diagnoses, it's medication in particular. So they want to know what medication work, what medication doesn't work, and what are the side effects of the medication. And now they are start thinking about what is the side effect of medication, not on your liver, not on the kidney, not on the heart and lung, but now they start bringing conversation about what's the side effect of this medicine for below the neck treatment on my brain, and which make things very different than other things.
No, great. Thanks, Moaz. Amy, another question for you is, can you share a bit about how inequities and racial health disparities impact cognition, and what are some of the efforts that are underway to address these issues?
So we know that Black and Hispanic Americans are more likely to develop Alzheimer's compared to white Americans. Certainly, inequities and racial health disparities have a significant impact on cognitive function through various factors. And so one of those factors is certainly biological factors. We know that this group of Americans, they also have an increased risk for diabetes and hypertension and other comorbidities. So it's really important that we take a look at special populations and ensure that we are doing all that we can do to improve the health overall, right? So here at the Alzheimer's Association, we continue to build partnerships because we know we can't do this work in a silo. We work with groups, we work with coalitions and communities to provide education. We're working on developing community action plans that support increasing the concern and awareness for Alzheimer's and dementia. Additionally, we know that we need to continue the work to increase diversity in clinical trials. So that continues to be a high focus for the Alzheimer's Association because this is what will create a path towards more of an equitable future as we look ahead.
And I'm sorry to keep jumping in,
No, please.
but I hope this conversation, something happens since the fall. So I think right now where we are in health equity in general, but specifically brain health equity, is zooming in more and much more focusing on how to solve the problem. So I want to share with you a couple of things that we made strategic decision for 20 years over here. And Katie, you might know this. We, Indiana University, has a 3 partner in the healthcare system. One of them is Ashkenazi Health, which is our safety net healthcare system that served the underserved. For example, in 2023, there has been more than 1 million outpatient visits provided by Ashkenazi. If you look at these outpatient visits, you'll see 54% were African American. In the area deprivation index, meaning very poor neighborhood, it was scored of 85. And close to more than 66% were Medicaid, 20% did not have any insurance. For that population, we know they will have a different risk profile for their brain. But what we have done at IU Health, we made sure, Indiana University School of Medicine, we made sure we make Ashkenazi our actual lab and bring the research to that area, not the other way around. And what we found, actually, if we just bring people, ask them to go half a mile from Ashkenazi to where our Alzheimer's disease research fit, that's a major barrier. That did not work. That led to significant or disrepresentation of this population in our clinical trial funded by NIH or pharmaceutical company. So we actually had to build infrastructure in Ashkenazi. So right now, for example, in Ashkenazi, we are building the infrastructure for amyloid lowering therapy. We've been embedding guides there since 2008, and we are now focusing a lot on Brain Care Navigator to overcome the major breakthrough of risk reduction. So I think it's important to know that. But the big thing we discovered after 20 years of doing this, we just published data in this population in primary care, 65 and older. If we find people who don't have a diagnosis, dementia or MCI by medical record, everything, but we actually did a brain health assessment on them, 60% plus of them have unrecognized mild cognitive impairment, and another 12% have unrecognized dementia. And if we look at the African American, that group, because 54% are African American, the African American have 2 times the odd of having these unrecognized dementia. So despite 20 years, we still have not been able to crack it. And that pushed us to create health equity zone embedded in our area. And now we are bringing over a brain health equity zone in that area to figure out on that type of coaching that Amy decide to that might require specific modification to meet the need of that specific population living in a very high-risk neighborhoods.
Now, I think that's a great point. And knowing your data and taking a look and really that population health approach to looking at your data through that dementia lens and going the extra mile to create access is really critical in this work.
Totally agree. So Patty, turning to you, can you share about your care partner journey with your late mom and specifically what it means to be a daughter of someone with younger onset dementia and how in particular you got connected with Lorenzo's house?
Yeah, thank you. Thank you so much, Katie, and thank you, GSA, and thank you for seeing families with younger onset dementia. So when we break the silence and share our stories, we empower ourselves, we dismantle stigma, and we shine light on an unseen community. We're talking about communities that aren't seen, that are underserved. Younger onset families aren't seen. So I'm Patty, the daughter of Linda, who so bravely walked with younger onset dementia. Our journey together profoundly shaped my life, and I am humbled today to share pieces of my story while recognizing that my voice represents millions of young people like me, the children of a parent with younger onset dementia. My mom illuminated every room she entered, and still beneath her radiant exterior, brain change appeared when I was in my 20s. For over 10 years, we witnessed heartache and challenges, but we still had many moments of connection. As I walked alongside my mom, I became her advocate and unwavering champion, and I discovered the power of empathy, compassion, and community. So today I get to carry those lessons learned, and for the rest of my life, I will continue to love like Linda. So after being a teacher for several years and then caring for my mom, I found Lorenzo's house as a daughter myself on this journey. I connected with our founder, Diana, on Zoom, and I finally felt seen and like I had found my home. And so today I'm honored to serve as our programs and outreach lead, where I walk alongside the sons and daughters like myself. No one understands our journey except us. Lorenzo's house is a place of healing, not just for me, but for so many others across the globe. We are Alexis Grace, the full-time care partner for her mom in Mississippi, Anderline, who had to choose between attending a university or caring for her mom in Kenya, Alicia, who walked this path as a teen in LA, Seda in Dubai, and Avi, a 9-year-old who wants to ride his bike all day but comes home to navigate brain change with his dad. Without Lorenzo's house, many of us wouldn't know where to find the strength, but together we do. At Lorenzo's house, our youth are our compass, and we are building global leadership by empowering young people like myself across the world, equipping them with the knowledge, skills, and tools they need to become advocates and leaders in the dementia space, future neurologists, nurses, doctors, researchers. So we are making life better for those that are walking with younger onset today and for those that come behind us.
Oh, thank you for sharing. Can you talk a little bit about the foundation of Lorenzo's house and how it started, and then share a little bit about the mission and the 3-pillar program?
Yeah, thank you so much. Lorenzo's house was founded in 2021 when Diana Shula Kosa's husband and the love of her life, Lorenzo, was diagnosed with younger onset Alzheimer's. Her boys were 9 and 13 at the time of diagnosis, and she was looking for care and community for herself as a young mom navigating this, but she was really looking for support for her boys, the sons of younger onset dementia. So because of her entrepreneurial background, she had built a network of charter schools on the south side of Chicago. She built Lorenzo's house for families like mine. Lorenzo's house has quickly become a trusted organization, and we are serving over 3,000 family members in 48 states and 17 countries. Our mission at Lorenzo's house is to empower the sons, daughters, and their families affected by younger onset dementia, those diagnosed or showing signs before the age of 65, by shifting the narrative. We cure isolation, build community, and drive dementia justice. We are doing community and care, and we are also building awareness. Our 3-pillar programs, which are our solution to this global problem, are our Match, Clubs, and Summit. Our Match is a one-to-one caregiver-to-caregiver connection with a peer who understands. When you're experiencing dementia as a daughter or a care spouse, the isolation and stigma can be so heavy. So by being connected with someone who understands, you feel like you have this connection, and it's this invisible string that ties all our programs together and helps to cure isolation. Our clubs are our virtual support groups. We have a Bright Brunch for female care partners, a Light Lounge for male care partners, but we also have our Light Club and Shine On, which are for the sons and daughters ages 4 to 35 plus. Our Light Clubs bring together youth from across the globe. It's a place to connect with others who understand, share our common stories, and build a growing youth alliance. These clubs are intentionally designed, planned, facilitated, and led based on the community. So our children's group will use play and picture books to talk about brain change. Our teens will meet to talk about how do we tell our friends about what is happening in our home? How do we navigate those moments of stigma when we're at our basketball game and our parent does something that maybe is a little different? And our young adults are really leading that space and building their resources and toolkit to really navigate this journey. And then our 3rd pillar program, which takes place in June every year, is our virtual youth summit. So free worldwide event that is designed by and for young people. It is a multidisciplinary event where we bring together social workers, neurologists, speech language pathologists, occupational therapists, art therapists, and we partner them alongside a youth lead, a young person who is walking this journey or has walked this journey. So we'll partner a 9-year-old with a neurologist, and they will lead a session on brain health to really, because a 9-year-old knows what they need because they are walking their journey and they know the journey more intimately. This year, we gathered over 30 youth leads as young as 9 who really built and led, and we partnered with leading organizations like AFTD and Us Against Alzheimer's and Dementia UK. And at Lorenzo's house, we truly lean in and listen. Our culture is one of continually positioning ourselves as learners, and we've learned that not only are young people looking for care and community and support. They're also looking to fight back on this disease and advocate and think about what we have called out as dementia justice. So this year at Summit, we hosted the first ever dementia justice panel, which brought together 5 young people from across the globe to really think about what they need and how they're going to make this part of this world a little bit better with younger onset dementia. So we need to find each other, we need to lean on each other, and we need to inform experts everywhere. So Lorenzo's house is here, and thank you for letting me share.
Thanks, Patty. It's really great to hear about all the work and how you guys continue to grow. It's fantastic. Laura, turning over to you. I understand that the Emory Integrated Memory Care is participating in the new CMS GUIDE program. Can you tell us about GUIDE and the service the program will provide people with dementia as well as their care partners?
Thanks, Katie. This is a really exciting time, I think, to be working in the Alzheimer's and related dementia space. There's a lot of really interesting developments, not just around prevention and treatment, but also around payment and looking at care for people who are living with dementia. And for the first time ever, Medicare has said and recognized that people living with dementia may need to be cared for a little bit differently. So they have set up a program called GUIDE, which stands for Guiding an Improved Dementia Experience. It is an optional alternate payment program that people could choose to apply for and participate in. So Medicare has recognized that in order to get really good dementia care, some things need to be done differently. So they looked at models like integrated memory care, the aging brain care model in Indianapolis, the program at UCLA, the Benjamin Rose Institute. There's lots of national comprehensive dementia care models across the United States. They looked at those models. All of the models operate very differently. We are primary care for people living with dementia at integrated memory care. That's unique to us. But across those different programs, there are some core components that we agree that this would mean that somebody was getting excellent dementia care. And this is the basics for what should be expected if you are going to get good care, not just for the person who is living with the diagnosis, but also for the care partners and the family members who are working to support them as well. And so part of this components is just, are they getting that diagnosis, right? It shouldn't be so rare. It should go without saying that people should get the diagnosis and then be told the diagnosis and be able to have an assessment of what stage they're in or what to expect when you have gotten the diagnosis. But we know that sometimes that is difficult to get reliably or correctly in a community setting. So people who are participating in GUIDE are committed to making sure that patients and families get that diagnosis and get that regular assessment. So not just once, but ongoing. How is the disease changing? How are things progressing? And what can we expect with that? We also know that care coordination for these patients and families is really important. How can families and patients access the community resources that they need when they need them? What's out there? How do they find them? So they need that care coordination and they need a care navigator in order to help them figure out where to go, how to get these services, and in some cases, which services are reliable, which services are the good ones to use, which ones would we not recommend so much, what are other families saying. So having an expert who can help guide you through this experience and these community resources is really important as well. They said having 24 access to this dementia care team was really important too. For integrated memory care, since we have opened, we have had an after-hours number for our patients and families to call when our clinic is not traditionally open. And this after-hours number has been really critical in preventing unnecessary hospitalizations and making sure that families feel supported during a crisis. Because it is very often that these things come up not in the hours between 8 to 5 when it would be convenient to call your provider. So when mom can't sleep at night and she is trying to go to work at 3 a.m. and the daughter doesn't know what to do, there is that after hours number to redirect them instead of the only option is let's take them to the hospital. So having that 24 access care can really help family members feel like they have a resource to get well-informed care recommendations that are specific to this dementia diagnosis. So guidance in an emergency situation. The other thing that is really critical in this dementia journey is making sure that family members, care partners have some anticipatory guidance about what to expect. I often say that the best intervention for someone living with dementia is a really well-informed and well-educated care partner. So somebody who knows how to de-escalate a situation instead of giving a medication is going to be far more effective than that medication in the long run. And the caregivers have to know what to expect. They have to know what symptoms may come up, and they have to have tools and strategies to help them deal with some of these circumstances that they may not have had to deal with before. So that caregiver education and caregiver support is really critical. We don't want a family member to find out that or to experience that, have the experience that their loved one forgets who they are. They should know that that is a common symptom of living with dementia for this memory challenge. But if my husband wakes up and doesn't know who I am, I'm probably taking him to the hospital because clearly something is very wrong. This couldn't possibly be happening. And so I think making sure families understand this and know what to expect can be really helpful in reducing some of those negative outcomes for patients and families as well. The other core component that is a part of GUIDE is having a home visit. So doing a safety assessment within the family's home. And for the first time ever, CMS has included care for the caregiver as well. So there is a respite payment if people qualify of $2,500 annually so that caregivers can get a break from the day-to-day responsibilities of caregiving. Or maybe they really need to go to that graduation or that wedding, but what are they going to do with the loved one at home? So now they have funds to be able to take care of their own personal needs as well. So it's a unique model of paying for dementia care that we hope will improve dementia care quality or reduce care costs for people who are living with dementia.
Thank you for explaining all that. It's great. Can you share a little bit about what it took for Emory to become a GUIDE site? And are there any learnings or tips you might have for others who are interested in this program or future programs that might be similar down the road?
I think to participate in the GUIDE alternate payment program, there was a call for applications. And so IMC applied and was granted the status as an existing site. So we have been open since July of 2024. For new program sites, they will start opening, I believe, in July of 2025. So they're planning for implementing all of these different components of the GUIDE program because they had not been doing that previously. Even though we've been providing comprehensive dementia care services since the IMC opened in 2015, we haven't done all of these core elements that GUIDE has stood up for us. So home visits was not a part of our model for each and every patient with an integrated memory care. So we've had to figure out what's the best, most effective, and what's going to have the best outcomes in our workflows for how to do this for patients and families. And that's an evolving process for us. I think who's the right person for that? What's the right tool for the job? So we may be working with partnering organizations. We had a nurse practitioner who did that as we started in July, and it's evolving at the moment. And then the other thing we have not done before is offered that respite payment. That's a really big deal and something that I think a lot of families are really looking forward to, and it's a big incentive for signing up for the GUIDE program for those people who are eligible. I will say for our patients and families, we have had to do more pitching than we were anticipating at the beginning because they said, we already get all of this at the integrated memory care. I don't know why I would sign up. So we just do a better job of explaining the benefits, maybe not right now, but in the future for what this could mean for them and their loved one. But we're really excited about this becoming a bigger piece of regular care. So maybe not everybody is trying to do primary care for people living with dementia like integrated memory care, but we're hoping with the implementation of GUIDE, more practices, more families are going to have access to high quality dementia care as some of these core components are implemented either in part or in whole across the country.
Just to clarify, unfortunately, if you did not apply to GUIDE and you were not one of the approximately 400 organizations there is no another call for coming in. So your only options will be, if you're a patient, is to find out the closest guide near you. So that's one. And the second, if you're not a patient, like a healthcare system, then you can partner with a guide close to you. So that's number one issue. The other issue and guide is you had to be Medicare Part A or Part B. You cannot have a commercial insurance, and you cannot be part of Medicare Advantage. And ironically, that percentage of people, Medicare beneficiary who are on Medicare Advantage, therefore they not qualify for guide, is growing and have passed the 50% just maybe a year or 2 years ago. And from our experience since July, and I'll give you an example, we anticipated that we will have around 200 people right away, because we are also an existing program, who will be qualified for guide. That number dropped to almost 25%. A lot of the other people went to Medicare Advantage or other group insurance that will disqualify them to guide. So I think guide is first, but what I'm hopeful for is with the Alzheimer Association, with the GSA, with other, we can broadcast the guide for Medicare Advantage company, which is, ironically, it will be, from a business perspective, is good for them. It will reduce their overall cost. That hopefully we can spread guide indirectly through Medicare Advantage and commercials, especially for the PADI type of patients who are not on Medicare because they are young onset Alzheimer's disease. They will not be qualified if they don't have Medicare Advantage. If they don't have Medicare Part A and Part B. And that is not fair, ironically. So that's a couple of things that I want to just highlight to you. In the guide, it took a lot of effort. I can tell you the guide has two components, as Laura said. You have the comprehensive dementia care program, but also you have the alternative payment model. In the comprehensive dementia care program, we knew it from 2006 when we published the original trial that demonstrate benefit, but we didn't know, there was no demand for that. So we were not able to create a demand until we developed the alternative payment model in 2018. And even after we do that, we had to build coalition, including the John A. Hartford Foundation, coalition across all of our group, like the Emory group, UCLA group, UCSF group, John Hopkins group, the Cleveland group, and the Nebraska group. But we had to team up with the John A. Hartford, with the Alzheimer Association, played a huge impact, the Alzheimer Association, because they know how to create a policy that will lead to alternate payment model. And the AARP came over. So a lot of work, 20 years of work to do it. And I don't want to wait another 20 years. And more specifically for me personally, I don't want this to be available just for patients with dementia in the United States, because, I diagnosed my mom with mild cognitive impairment related to Alzheimer's disease. And after losing my father in May, after almost 6-7 years, but she doesn't live in the United States. And we're going to need to be much more organized and smart to really share these three breakthrough and overcome the stigma in the United States and across. And this is why this kind of webinar and work that you're doing, Katie, it's so crucial, because if we keep these patients not recognized, like what we found even in our system, that 62% of 65 and older have unrecognized mild cognitive impairment. If we, in the Davos project, as in the DAC, it's trying to build the system to be able to start this dialogue and go from there.
Yeah, thank you for sharing your perspective on guide and some of the challenges we still have ahead of us. It's a great call to action. So Milan, just a follow-up on this too, is now that there are anti-amyloid therapies for patients, what does this mean for your practice? And has the availability of these new treatments changed your approach to working to a workup or a conversation with the patient and their family?
Yeah, our practice have went through multiple phases. So our first phase was focusing on improving the care of people with recognized dementia. And we developed the model, we implemented. We've been focusing on scaling it up Our first version was delivering the model by nurse practitioner. Right now, the majority of our model is delivered by community health workers. And our future is delivering the guide through a conversational AI, so from a scale. So that's one piece. Then we start when the breakthrough in lowering your future risk for developing dementia, the stuff that Amy highlighted, and the last year and a half, 2 years, the FDA approval for amyloid lowering therapy, that shift, that gave us more and more momentum to start going to the early detection. So we become obsessed about timely, scalable, sustainable detection of people who are at risk for developing, those who have maybe mild cognitive impairment, and then those who have mild dementia. And why these three things? Because at risk, you already know that what Amy said, these 10 risk factors, including, depression in particular, and other stuff. The amyloid lowering therapy, the 2 FDA approval, do not work if you have moderate dementia, and do not work if you don't have Alzheimer's disease as the underlying pathology for your dementia or mild cognitive impairment. So that led to 2 things. Led us to start becoming more focusing on the early detection. The second one, now we can't just go with my history to say 90% I think your mild cognitive impairment due to Alzheimer's disease pathology, or 90% I think your dementia is due to Alzheimer's disease pathology. I have to be 100% sure. What that means, I have to get a confirmation of a biomarkers for Alzheimer's disease. And now setting up the system for picking up people with mild cognitive impairment or mild dementia or at risk, and setting up the system for allowing us to do a confirmation that they have Alzheimer's disease pathology. And then they will be qualified for potentially for having conversation on FDA. But then the other piece we have to overcome is we need these medications, the amyloid lowering therapy, they have risk profile, and that risk profile is predictable. For example, if you have a EPOE genotyping that is give you an allele, we call it EPOE4, 1 allele or 2 allele, your risk of getting harms from medication is substantially different. So we have to do genotyping in that process. And then the big thing that we have to do is we need to have time to have the conversation for these amyloid lowering therapy, the conversation for the risk profiling, and even the conversation to enroll to guides, all right? And as conversation require time, and time does not exist in the current healthcare system. So with that background, we had to redesign the current healthcare system and shift it. So number one, early detection. If you focus on early detection, you cannot go to memory care practice. It's too late. When the people, they come over to me, they already are much more advanced, and I will be missing a lot. So we have to focus on where? On primary care, and even community care, and work with the primary care and community care. In primary care, community care, their workflow is very different than memory care. So I'll give you a great example. I practice in memory care, but I'm the medical director of our primary care aging brain care program. So when I practice in memory care, my panel, I have around 200 patient panel, almost 90% of them are at risk for developing Alzheimer's disease, have mild cognitive impairment, or dementia syndrome. So technically, I don't even need to do a random allocation. I can just make the assumption everybody has risk and give them this. If you go to primary care, that is very different. Only 45 people from a panel of 1,500 have some type of dementia syndrome. Maybe another 100 have mild cognitive impairments, and that's it. 5 to 10%, maybe 20%. And if that's among 65 and older, but primary care docs are taking care of people, family medicine, young and older. So that's the prevalence is very different. So I have to redesign the primary care for that perspective. And we've been working on it, and we've been able to do it. And we have to think outside the box, and we start thinking about any kind of strategy, especially given that we do not have demand for early detection, by the way. There is no demand. There is no alternative payment model for early detection. Okay, so that's the big one. So we had to think in a very scalable way. So our big strategy right now for us, at Ashkenazi, we need to have what we call 0 minute, less than $1 cost for early detection. That's our strategy. What that means is we have to bring over other setting outside the primary care. We have to empower the care partner in that piece, because ironically, the care partner care about their loved one, even if you don't pay them money. Like you see it at Patty, correct? Patty care a lot, not because she does, I don't need to pay her. She care more. She'll actually come over and pay me to take care of her mom, all right? So for that piece, we have to go to the caregivers. We have to empower them. We have to do the care partner of them. That's important. And then the other one, we have to leverage artificial intelligence, all these passive data that exist in our health record, and think outside the box to make sure everybody have access to these 3 breakthrough that Amy went over, Laura went over, and this, what I'm talking over, the amyloid lowering therapy.
Yeah, thank you. Can you talk a little bit more about the ongoing research at IU and how your system is standardizing cognitive evaluation as part of primary care, since I know that's been a big shift in the past couple of years as well? In particular, I know you're doing some work with the 5-cog paradigm. And are there any early learnings in this program that you can share?
Yeah, so IU, Indiana University, and we are very lucky because we have access to 3 different healthcare systems. I described what's going on in Ashkenazi. And in Ashkenazi, our early detection strategy has been a combination of what we call a brain care navigators and passive digital markers. Our passive digital marker look at the data left behind, and our people who are 65 and older run an artificial intelligence to find those folks who are at risk for developing dementia or actually have dementia or mild cognitive impairment. And we bring them over and we use computerized decision support during their encounter with their regular doctor to say, this patient at high risk, we're going to go ahead and refer them to your brain care navigator to do it until you tell me otherwise, right? So we do what we call opt-in until you tell me opt-out. So that's one, the passive digital marker. The other one is our brain care navigators who are helping taking the plate off the primary care doctor if they don't want to, if they don't have the time, and they can confirm the diagnoses. And based on that, they can see if they qualify for dementia, then they give them into the guide. And our brain care navigator there act as a guide brain care navigator. If they are eligible for amyloid lowering therapy, then we are trying to set them up for the amyloid lowering therapy and go over all the logistics, getting insurance approval, meet all the requirements for doing all these kind of things. And then if they are at high risk, but they don't have mild cognitive impairment or dementia, then we work with them and coaching them on how to reduce their risk. So brain care navigator, passive digital marker, that's in Ashkenazi. And IRU health system, which is much, much bigger than Ashkenazi. It's covered the entire state. And over there, we have also, by the way, what we did with Ashkenazi, we would never able to do it without the support from the NIH. All of our solution, our R&D budget from Ashkenazi was 0. Our R&D budget came all from the NIH, all right? So what Ashkenazi have done, took our R&D budget from NIH and removed any barriers of having a lab in Ashkenazi. And then when we found solution, work with them, work with us to implement it, not wait for another 17 years to become real. So that's what Ashkenazi done. In IU Health, which is a statewide piece, and we have a lot of basic science leverage over there, we have developed a brain care navigator for early detection. So ironically, the brain care navigator in Ashkenazi was for guide for dementia. The brain care navigator, the first version in IU Health, was for early detection for amyloid lowering therapy and enrollment in clinical trials. And now we brought them together and say, oh, brain care navigator, you are brain care navigator, you're triaging for everything, for the risk profile, risk modification, the guide, and the amyloid lowering therapy and other stuff. So our brain care navigator concept was there. In IU Health, we are testing another things because what we struggle with, if you have a patient or care partner who do not think there's a problem with their loved one, all right? Even when we do the passive digital marker for them, there's still 50 to 70% of them, they don't contact the brain care navigator. They say, there's nothing wrong with me. I'm not going to show up. All right. Especially if they already have a stigma. They already say, oh my gosh, if my doctor find out that my loved one has dementia, they were going to put them in a nursing home. Or the patient will say, oh, they're going to take away my driver license. Or the other one, oh, they're going to cheat me. They're going to take away my dignity. So we found out if people are not knocking on our door to say, please worry about my brain care and brain health, when we come over and knock on their door, especially if we are a little bit stranger, they're not going to open the door. And over us to overcome that, what we did, we tried to do in the 5-cog study, we tried to convert people from asymptomatic or perceived as an asymptomatic to be symptomatic. And when we do that, we did something very simple, simply asking them, do you have a problem with your brain? Did you hear from your care partner that have a problem with your brain? Do you think there's been decline in your brain in the past 10 years? And if the answer is yes to any of them, we call you subjective cognitive complaint, and we hand you over through our electronic health records based computerized decision support to our brain care navigator that will follow on that piece and go from there. And our original study, which was done in the Bronx, showed that type of strategy increased the odds of having new diagnosis of dementia by 8 times, 800%. And that paper was published in Nature by Joe Verghese, our colleagues. Now we are trying to study it and see the barrier and facility for implementing that program in rural area, urban area, and suburban area.
That's great. Thank you for sharing. Looking forward to hearing more about those in future GSA meetings. So just in our final few minutes, I just would love to go around to each one of you and ask for you to share your thoughts on what are you most excited about in this field? What are some of the innovations on the horizon that you think would make a meaningful difference for patients and their families? Amy, do you want to kick it up?
Sure. I think this is an exciting time for everything that's happening in this field. We've covered GUIDE. We've talked about treatment now. When I started with the Alzheimer's Association in 2019, during that year, we had a facts and figures special report about dementia care within primary care. And we heard from primary clinicians from across the country, time was a barrier. There was not a disease-modifying treatment. That was a barrier. Not enough resources and support and reimbursement out there. That was a barrier. And even though it's not perfect, GUIDE is not perfect, the treatments we have, they're not perfect. It's a slowing the progression, right? But we're making some progress. And at the Alzheimer's Association, we continue to work with our health system partners in developing strategies for increasing early detection. And what might that mean? Looking at things that we know are on the horizon, more digital cognitive assessment tools that might make the job easier within primary care to assess patients, things like blood biomarkers and what that might mean and those doors that could open. So it's certainly an exciting time. I think it's also a time that we also have to realize that not everyone qualifies for GUIDE. Not everyone will qualify for a treatment. So we have to also make sure that we're doubling down on the support for patients and caregivers and making sure that they have access to not only support groups, but education, to material. They understand who's in their community, who to go to. So it's our time certainly as well to ensure that we're doubling down on the support for those impacted with this disease.
Great, thanks. Patty, your thought?
Yeah, I would agree that early detection is what is the most exciting for myself and for Lorenzo's house personally, because it allows our families who so often go through multiple misdiagnoses before getting an accurate diagnosis to get an accurate diagnosis and to get access to a quality care team that can support them with the different supports. For us as a support, the Alzheimer's Association as a support, finding that community so that they can really live their best lives for as long as possible on this journey. My mom and I could find love and care and connection every single day. And so I would want that to be what could happen for family members that are affected. And especially with younger onset dementia, being able to have an accurate diagnosis. And so these new diagnostic tools are just really exciting so that families can know what's happening and then find a community that really understands. Thank you.
Laura?
I think what is really exciting about all of these developments in the Alzheimer's and related dementia space is I'm hoping that all of these different developments will help normalize talking about brain health and normalize assessing that and not just looking at what happens below the neck, as was said earlier, as an important piece of your health. So hopefully we are moving towards reducing that stigma when we're talking about dementia. And I think it is really also incredible that systems are recognizing that it isn't just the person living with the disease that is impacted by this, but there are significant efforts and resources being available to care partners and caregivers who are alongside the people who are living with this disease in the journey as well. So all of that is really exciting. I think we have a lot to look forward to.
Great. Last final thoughts?
Yeah, I think I will echo everything said already. I think the three breakthrough give us a good weapon to overcome the stigma. So that's very important. The three breakthrough give us opportunity to focus on overcoming problem with access. Given now we have three breakthrough, we want to make sure access to these three breakthrough will be helpful. And then the other opportunity that we have is finally, I think our research is start becoming more inclusive research. What I mean about that is we start thinking more about the generalizability of our research. We call it external validity, not just our internal validity. We start thinking now more and more on what I call it the impact equation. So if you have a solution that trying to solve a problem that affect large number of people like Alzheimer's disease and other related cognitive disorder, then your solution has to be not just produce a large, what we call in epidemiology jargon, effect size, but has to be implementable, scalable, and sustainable. And this concept of impact, it's become a paradigm shift in our research community. We start thinking about what I call constraint in our solution, not just simply say, imagine you have unlimited resource, can you do? That kind of imagination lead to inequity, lead to discrimination potentially, and lead to a significant access problem.
Good point. So with that, thank you for everybody for joining for this webinar. We hope you found it informative and enjoyable. Thank you so much to the members of the GSA Care Supporter Circle, including ASI, Genentech, Lilly, and Otsuka for their support of this Momentum discussion. Thank you to these panelists, Amy, Patty, Laura, and Malaz. Really appreciate you joining for this discussion and sharing your thoughts and insights, as well as your hope for a future in the field. So thanks, everybody.
Take care. Bye.
Which is your gateway to a library of engaging learning resources. Access toolkits, courses, webinars, and more podcasts, all tailored to support your interest and advancement in the field of aging.